A simple, annoying pimple right on the bridge of your nose. Or, maybe an ingrown hair just above your upper lip. You look in the mirror, you get annoyed, and you squeeze it.
Right, yeah. We all do it.
Exactly. It's a completely universal, almost unconscious habit we all have. But what you probably don't know is that right beneath the surface of that specific patch of skin lies a biological trapdoor.
A very dangerous one.
Yeah, because when you apply that mechanical pressure, you're potentially forcing bacteria directly into an open valveless highway. I mean, a venous channel that leads straight back through the thick bones of your skull and empties directly into a massive pool of blood resting against the base of your brain.
It's a really sobering anatomical reality. A surface-level blemish, if manipulated the wrong way, can initiate this cascade leading to a catastrophic, life-threatening neurological infection.
Wow.
And the reason for this lies entirely in the unique and frankly paradoxical way the human face is constructed.
Which is exactly why today's deep dive is going to fundamentally change the way you look in the mirror. We are pulling apart Chapter 8 of the textbook of Head and Neck Anatomy by Hyatt and Gardner.
It's a dense chapter for sure.
It is, but we are not here to just read you a dry textbook laundry list of Latin muscle names and blood vessels. That does you no good. Our mission today is to build a high-fidelity, three-dimensional mental model of the superficial face and the scalp.
Precisely. We need to understand how this region is engineered to do three incredibly demanding things. First, to communicate the vast spectrum of human emotion. Second, to fiercely guard our orifices from the outside world. And third, to constantly supply the high metabolic demands of tissue that is, perpetually exposed to the elements.
Right. And as we construct this mental model, the core philosophy we need to anchor our entire discussion to is this. We are engaging in the study of structure in service of function.
That's the anchor. More importantly, we're going to see exactly how that very structure shapes disease, how it dictates surgical intervention, and ultimately determines clinical outcome.
Because the anatomical adaptations that allow humans to smile, to frown, to survive in freezing temperatures, those are the exact same structural quirks that create highly unique and sometimes fatal clinical vulnerabilities.
Yeah, it's a fascinating trade-off.
So if you run your finger along your jawline right now or blink your eyes, think about what's actually happening under the skin. If you picture the rest of the human skeleton, it's mostly it's a system of basic levers and pulleys.
Bone pulling on bone.
Exactly. A bicep muscle pulls on a forearm bone, the elbow joint closes like a hinge, and you lift a cup of coffee. It is mechanical. But the face throws that entire mechanical rulebook out the window.
It really does.
If the facial skeleton, those 14 delicate bones, acts as the rigid scaffolding of a theatrical stage, then the skin of your face is the stage curtain. And the muscles aren't pulling bone to bone. They're the riggers, floating in the tissue, pulling directly on the curtain itself.
It is a profound structural shift from the rest of the body. And to orchestrate this theatrical stage, the face relies on two completely separate, highly segregated electrical grids.
Two grids, okay.
Right. One grid is an exclusive command center sending signals out to the riggers to move the curtain. That is your motor system. Meanwhile, an entirely different isolated grid acts as the audience feedback system, constantly reporting back to the brain on temperature, touch, a gentle breeze, or sharp pain. That is your sensory system.
So we're going to map the wires, the plumbing, and the trapdoors of the face. And whether you are a medical student trying to make sense of your anatomy labs or a surgical trainee terrified of leaving a disfiguring scar on a patient, a dental student tracing a nerve block, or just someone fascinated by how their own body works, understanding these structural rules is the absolute difference between rote memorization and true clinical intuition. Let's start at the very top, the roof of the stage, if you will, the scalp. Now, when most people hear the word scalp, they just think of the skin on their head and their hair. But structurally, it is a highly engineered, multi-layered helmet.
Precisely. It stretches over the 8 bones of the cranial vault, which we call the calvaria. And in anatomy, the word scalp is actually used as a highly effective mnemonic for its 5 distinct structural layers.
It's quite convenient.
It's a brilliant way to conceptualize the mechanical properties of the region, layer by layer, moving from the outside in.
Okay, let's walk through them. Layer 1, the S, is the skin. It's thick skin, normally covered with hair and rich in sebaceous glands. Simple enough. Then we drop down to layer 2, the C, which stands for connective tissue.
But this isn't just any connective tissue.
Right.
This is a fibroadipose hypodermis. It is fatty, It is fiercely fibrous, and it is incredibly dense.
And the density of that second layer is crucial because those first two layers, the skin and the dense connective tissue, are tightly, inextricably bound to the third layer, the A.
The A stands for the aponeurosis, specifically a structure called the galea aponeurotica.
The galea aponeurotica. Honestly, it sounds like the name of a Roman gladiator.
Functionally, it does act like armor, so the name fits. The galea is a thick, incredibly tough, fibrous, tendinous sheet. And it serves a very specific mechanical purpose. It connects two distinct muscular bellies across the vast expanse of the top of your head.
Right. This is the epicranius muscle, or as it's sometimes called, the occipitofrontalis. You have the frontalis muscle belly in the front, sitting over your forehead, and the occipitalis muscle belly in the back, sitting over the base of your skull.
Exactly.
And this fibrous sheet, the galea, spans across the top of the cranial vault like a tight bathing cap, bridging those two muscles together.
What is truly fascinating here is the mechanics of how these muscle bellies originate and insert. The occipitalis in the back originates from solid, unyielding bone. Specifically the mastoid process of the temporal bone and the superior neutral line of the occipital bone at the base of the skull.
So it's firmly anchored.
Right. That posterior bony attachment anchors the entire system. But the frontalis, the larger and fleshier muscle belly in the front of your forehead, does not attach to bone at all.
Wait, really? It just floats. Where does it originate from then?
It originates by blending with the superficial muscles of the upper face, the muscles surrounding the orbit of the eye and the bridge of the nose. It intertwines with them, and then its fibers travel upward to insert directly into that tough galea aponeurotica.
Oh, I see. So when you raise your eyebrows in surprise or, furrow your forehead to create those horizontal wrinkles, that's the frontalis contracting.
Yes, exactly.
And because the occipitalis is anchored to bone at the back of your head, the two muscles acting together essentially pull that tendinous sheet tight over the dome of your skull.
Exactly. They operate as a single functional unit. There is also a variable set of muscle fibers on the side of the head called the temporoparietalis, which extends from the frontal belly down to the fascia of the ear. It can slightly elevate the ear, though it's quite vestigial in humans.
Okay, so if you take your hand right now, put it flat on top of your head, and wiggle your scalp back and forth, what you are feeling is layers 1, 2, and 3. The skin, the dense connective tissue, and that epicranius muscle with its aponeurosis. They're moving as one single unified block.
Yes, and they are sliding over what lies beneath them. Which brings us to the L in our SKLT mnemonic, layer 4, the loose connective tissue.
Right, layer 4.
This layer is often referred to as the fascial cleft. Imagine a layer of spongy, loose areolar tissue. Its primary biological function is to act as a glide plane, allowing those upper three rigid layers to shift and slide smoothly over the static skull.
But from a clinical perspective, layer 4 is almost universally known in medicine as the danger space of the scalp.
The danger space.
Okay, let's unpack this. Why is a layer of loose tissue dangerous?
Because architecturally, it acts as a massive subaponeurotic trapdoor. It is a vast, continuous, unrestricted space with virtually no structural boundaries to stop the spread of fluid.
So if there's bleeding.
Right. If a patient suffers a head trauma resulting in a hemorrhage, or if an infection is introduced deep into the scalp, the fluid pools within this loose tissue, trapped deep beneath the impenetrable roof of the galea aponeurotica.
So the thick gladiator helmet layer prevents the fluid from just swelling outward and bursting through the skin. It's trapped underneath.
Precisely. It has no superficial outlet. And because it is trapped, the accumulating pressure forces the blood or the pus to seek alternative routes. Fluid will always take the path of least resistance.
Naturally.
And this is where the anatomy becomes genuinely perilous. Passing vertically through this loose danger space, you have a network of vessels called emissary veins.
Emissary veins.
Yeah.
Like an emissary or a diplomat crossing a border.
A perfect analogy. These veins act as bridges. They connect the superficial venous system on the outside of your scalp, and they dive straight down, piercing through the solid bone of the skull. They travel through the diplo.
Hold on, I'm going to stop you there. Diplo, you've lost me. What is diplo? Let's explain this simply for a second.
Apologies. If you imagine the bone of your skull like an ice cream sandwich, you have a hard, dense layer of bone on the outside and a hard, dense layer of bone on the inside.
Okay, the cookies.
Right. The diplo is the ice cream in the middle. It is the spongy, porous, honeycomb-like bone marrow sandwiched between those two hard cortical plates.
Okay, got it. So these emissary veins dive from the loose danger space of the scalp, through the outer hard bone, through the spongy diploe, and then where do they go?
They continue right through the inner layer of hard bone and empty directly into the dural venous sinuses of the brain. The dural venous sinuses are essentially massive venous rivers built into the tough membrane surrounding the brain, draining blood directly from the cerebral hemispheres.
Wow, so you have a physical blood vessel connecting the outside of your head, just under the skin, straight into the main venous drainage of the brain. That seems like an unbelievable design flaw.
It is a significant vulnerability, particularly because these emissary veins are valveless. There are no one-way turnstiles to enforce traffic direction.
And that's bad.
Therefore, a localized abscess or an infected laceration in that layer 4 danger space can migrate inward along these veins. This can result in osteomyelitis, which is a severe infection of the skull bone itself.
Sounds worse, right.
Much worse. Far more catastrophically, the bacteria can reach the brain's drainage system and cause a thrombosis, a massive infected clot, within the dural venous sinuses. It is a direct, open highway from the surface of the head to the brain, and it can absolutely be fatal.
That is terrifying. To think a deep scrape on the head could lead to a brain infection just because of a loose layer of tissue and some valveless veins.
Yeah.
And right beneath that danger space is our final layer, layer 5, the P, the pericranium.
The pericranium is simply the anatomical term for the periosteum of the skull. It's the fibrous vascular membrane that tightly coats the outer surface of the cranial bone.
And it's loose, right?
It is relatively loosely attached to the smooth, flat surfaces of the bone, which is another reason that danger space can expand so much. However, it is firmly, tightly anchored down into the suture lines. Those are the zigzagging joints where the individual skull bones fuse together.
Which explains why, if someone has bleeding in that loose danger space, the swelling might pool and stop at certain boundaries on the skull because the pericranium tacks it down at the sutures.
Exactly. It creates distinct fluid boundaries.
Okay, so that is the structural framework of the SCA-PE. But we need to go back to layer 2 for a moment, the dense fibroadipose connective tissue, because there is a mechanical paradox in the scalp that every single clinical listener needs to understand.
Yes, the paradox of hemostasis in the scalp.
Right. Hemostasis is the body's ability to stop bleeding. The blood supply to the scalp is incredibly rich. You have branches coming up from the external carotid artery in the neck and branches coming from the internal carotid artery inside the skull.
And they all freely communicate and intertwine with each other across the head.
But these vessels are traveling directly through that thick, rigid, fatty, fibrous layer 2.
To understand the clinical implication of this, we need to look at the normal mechanics of hemostasis. If you are chopping vegetables and you accidentally slice your finger, you sever a blood vessel.
Right, and it stops bleeding eventually.
Instantly, the smooth muscle in the wall of that severed artery will spasm and contract. The vessel will literally retract into the surrounding loose tissue, and the internal lumen, the pipe itself, will narrow dramatically, slowing the blood flow and allowing platelets to build a clot. That is the body's natural tourniquet.
But in the scalp, the analogy I always use is to picture a flexible rubber garden hose running straight through the middle of a solid cured block of concrete. If you take a sledgehammer and an axe and you chop right through that concrete block, slicing the hose in half, that hose cannot pinch itself off.
No, it can't.
The rigid concrete is glued to the outside of the hose, physically holding the cut ends wide open.
That is an exceptionally accurate mechanical analogy. In the scalp, the dense connective tissue, the tough fibrous septa of the hypodermis, tightly bind the outer walls of the arteries and veins.
So they're trapped open.
Yes. When the scalp is lacerated by a trauma, say, a patient is thrown from a bicycle and strikes their head on the tarmac, those fibrous bands mechanically inhibit the blood vessels from contracting and spasming. The surrounding tissue refuses to yield, so the vessels are held permanently patent. They are locked wide open.
So you have a massive network of blood vessels fed by 2 major arterial systems that physically cannot shut themselves off when cut.
Exactly. And the clinical presentation is dramatic. Scalp lacerations bleed profusely, alarmingly so.
Even small ones.
Oh, a relatively small 2-centimeter cut on the head can result in a tremendous volume of blood loss, often covering the patient's face and clothes, looking like a major trauma. It can be extremely difficult to achieve hemostasis with simple light pressure because the structural integration of the vasculature and the dense fascia directly overrides the body's normal physiological response.
You literally have to push hard enough to compress the vessel against the underlying bone of the skull to stop the bleeding.
Yes, deep, firm pressure against the calvaria.
Okay, let's step down from the roof and walk onto the main stage of the face itself. We mentioned in our introduction that the facial muscles are unique because they pull on the curtain, the skin, rather than moving joints.
Right.
But to truly understand why they are built this way and how they function, we have to look back in time. We have to look at their embryological origins.
The developmental pedigree of these muscles is the key to unlocking their anatomy. All the superficial muscles of the face, and indeed the epicranius of the scalp we just discussed, share a single distinct point of embryological origin, the second pharyngeal arch.
Okay, I need to jump in here and play the role of the confused student. Second pharyngeal arch. What does that mean? I'm picturing like the arches of a cathedral. Are we talking about gills? Let's break this down.
It's a fair question. During the very early weeks of embryonic development, around the 4th week, the head and neck region of the embryo develops a series of paired swellings on the outside, somewhat resembling the gills of a fish.
Okay.
These are the pharyngeal arches. There are 6 of them, though the 5th disappears. Each arch contains a core of mesenchyme.
Mesenchyme, another jargon word. Are we essentially talking about embryonic stem cells here?
Essentially, yes. Mesenchyme is a loosely organized embryonic connective tissue that has the potential to differentiate into various structures: bone, cartilage, lymphatic tissue, and crucially, muscle.
So it's the raw building material.
Right. The mesenchyme inside the second of these arches, which is also known as the hyoid arch, is destined to become the muscles of facial expression. As the embryo grows, the specific pocket of mesenchyme migrates outward. It physically travels from the neck region, spreading upward and forward like a sheet across the scalp, around the ears, down the neck, and predominantly across the face, differentiating into this incredibly complex network of thin, flat muscles.
So every single muscle that moves your skin to smile or frown started in this one specific pocket in the neck of the embryo and migrated outward.
Yes.
And the golden rule of anatomy is that a muscle brings its original wiring with it.
That is the rule. A muscle's nerve supply is an indelible record of its embryological history. Because all of these muscles arise exclusively from the second pharyngeal arch, every single one of the muscles of facial expression receives its motor innervation from the specific nerve assigned to that arch. Cranial nerve the 7th, the facial nerve.
That simplifies things immensely. If it moves the face, it's cranial nerve the 7th. But let's get into the mechanics of these muscles, the rule of insertion.
The structural shift.
Right. In my arm, my bicep originates on my shoulder blade, crosses the elbow joint, and inserts onto my radius bone. When the muscle contracts, it shortens, and because it crosses the joint bends.
Yeah.
But in the human face, there are no joints being crossed by these superficial muscles.
Most of these superficial facial muscles originate on the static bones of the facial skeleton, the maxilla of the upper jaw, the mandible of the lower jaw, the zygomatic bone of the cheek. But they do not insert onto another bone.
They grab the curtain.
Instead, their fibers travel outward and insert directly into the deep surface of the dermis, the skin itself. And furthermore, their fascicles, the individual bundles of muscle fibers, do not exist in pristine, isolated anatomical envelopes. They freely intermingle. They weave and blend with the fibers of adjacent muscles.
So when I smile or grimace or raise one eyebrow, it is not just one distinct muscle pulling a single string like a marionette. It is a highly coordinated symphonic orchestration of multiple intermingled fascicles, all tugging on the underside of the skin in different vectors simultaneously.
Precisely. Their primary biological function is to manipulate the soft tissue surrounding the major orifices of the face: the orbit of the eye, the nasal cavity, and the mouth.
Not just for looking good.
No, by dilating, constricting, or elevating the tissues around these openings, they regulate the orifices for fundamental survival functions: vision, respiration, and feeding. But as a byproduct of this precise mechanical control, they broadcast the complex visual signals that we interpret as nonverbal communication, emotions.
So let's break these muscles down by the orifices they guard, because that is the most logical way to build our mental model. Let's start with the orbit, the eyes.
The primary guardian of the visual orifice is a muscle called the orbicularis oculi. It is a broad, flat, elliptical sheet of muscle that completely surrounds the bony orbit, and it is functionally divided into two distinct parts based on the demands of the eye.
Okay, two parts.
The inner ring, which rests directly over the delicate skin of the eyelids, is called the palpebral portion.
Palpebral, just meaning eyelid.
Yes. It originates from a small ligament on the inside corner of the eye, the medial palpebral ligament, and its fibers sweep across the lids to insert into a raphe a connective tissue seen on the outside corner. Its job is delicate, precise, and constant, the light closure of the eye.
Like blinking.
Exactly. This is the involuntary act of blinking, sweeping across the globe to spread a film of tears and protect the cornea from desiccation.
It's the windshield wiper setting, and then you have the outer ring.
The outer ring is the orbital portion. It traces a much larger, wider oval around the solid bony rim of the orbit itself. Its fibers are thicker and more robust. When the orbital portion contracts, it produces forceful, tightly clamped closure of the eye.
So squinting.
Right. This is the protective squinting you do against blinding bright sunlight, a cloud of dust, or the anticipation of a physical impact to the face. So within one muscle, you have a dual mechanism. Light, rapid, reflexive sweeping versus forceful, protective clamping.
You're deep to the orbicularis oculi, hiding right at the medial end of your eyebrow, near the bridge of the nose, is another smaller muscle, the corrugator supercilii.
The corrugator is a fascinating muscle of expression. It originates from the superciliary arch of the frontal bone, the bony ridge above your eye, and its fibers project outward to insert into the skin of the eyebrow.
What does it do?
When the paired corrugator muscles on either side contract simultaneously, they draw the eyebrows medially toward the midline and inferiorly downward. They pull the eyebrows together.
It creates those deep vertical wrinkles right above the bridge of the nose. It is the classic frowning, scowling, or deep concentration muscle. If you are staring hard at a difficult maths problem, your corrugators are firing.
Oh, absolutely.
Now, moving down from the eyes to the nose and the ear, the textbook mentions the auricular muscles, the anterior, superior, and posterior auriculars that attach to the cartilage of the ear.
Yes, these muscles originate from the fascia of the scalp in the mastoid process, and they insert into the auricle, the external flap of the ear.
Do they actually do anything for us?
In many mammals, think of a dog or a deer, these muscles are robust and crucial for survival, allowing the animal to independently pivot the ear funnel toward the source of a sound to detect predators. But in humans, they are largely vestigial remnants. We don't rely on them, so they've lost their bulk and tone, though you will occasionally meet someone who retains enough motor control to consciously wiggle their ears.
Which is a great party trick, but not terribly useful for survival. For the nose, however, we have three distinct muscles that are quite active.
Yes, the nose is active.
You've got the procerus, which sits right on the bony bridge of the nose and pulls the skin downward, creating those horizontal wrinkles between the eyes when you sneer, and then the nasalis and the depressor septi.
The nasalis is a two-part muscle. The transverse part spans across the cartilaginous bridge of the nose, compressing it, while the alar part inserts into the wing, or ala, of the nostril. Working in concert with the depressor septi, which sits just lateral to the philtrum above your upper lip and pulls the septum down, these muscles act to dynamically manipulate the nostrils.
Which is vital for respiration. If you are sprinting or struggling for breath, you reflexively flare your nostrils to widen the airway and increase air intake.
Or if you smell something foul, you constrict them.
Again, the muscles are manipulating the orifice for survival, and we read the resulting facial change as emotion.
Exactly. But the architecture we have discussed so far pales in comparison to the complexity of the final orifice, the mouth.
Oh, the mouth.
The mouth is the most expressive, the most mechanically demanding, and the most heavily used orifice on the human face. And at the exact center of this intricate web is a muscle called the orbicularis oris.
The sphincter of the mouth. But just calling it a simple round sphincter feels like a massive understatement based on how the chapter describes it.
It is a profound understatement. The orbicularis oris does completely encircle the oral opening, but it is not just a simple, isolated ring of muscle fibers like a rubber band. Its fibers exist in 3 dimensions, positioned at varying depths and angles within the substance of the upper and lower lips.
It forms more of an ellipse.
An ellipse formed by a highly complex composite origin. Some of its fibers do arise directly from the bone of the maxilla and mandible near the midline, but the vast majority of its bulk is created because fascicles from almost every other muscle in the lower face converge, dive into the lips, and intermingle to literally become part of the orbicularis oris.
Like a central station.
It acts as the central anatomical hub of the lower face. When it contracts gently, it closes the lips. During stronger, isolated contractions, it can purse them, protrude them outwards, as in whistling, kissing, or sucking on a straw.
And pulling on that central hub, you have an entire opposing team of elevators and depressors. Let's look at the elevators first. The muscles that pull upwards against the orbicularis oris to lift the upper lip and the corners of the mouth. You've got the zygomaticus major and minor coming off the cheekbone.
The zygomaticus major is widely known as the classic smiling muscle. It originates on the temporal process of the zygomatic bone, the prominence of your cheek, and its fibers run diagonally downwards to insert straight into the angle or corner of the mouth.
And it lifts.
When it contracts, it pulls the corner of the mouth upward and laterally outwards, creating a smile. The zygomaticus minor sits just medial to it, closer to the nose. It helps to elevate the upper lip directly and deepens the nasolabial furrow, the crease that runs from your nose to the corner of your mouth.
Then you have the levator labii superioris, which straight up lifts and protrudes the upper lip. And then we have my personal favorite muscle name in the entire human body, purely for how absurdly long it is. The levator labii superioris alloquinasi.
It is a mouthful, but the Latin is perfectly descriptive. Levator means lifter, labii superioris means upper lip, alacum means, and the wing, nasi, means nose.
It's very literal.
It is a thin slip of muscle that runs straight down the side of the nose and physically splits into two. One medial slip inserts into the cartilage of the wing of the nose to dilate the nostril, and the lateral slip continues down to insert into the upper lip to elevate it. It is colloquially known as the Elvis lip curl muscle.
The sneer muscle. You also have the levator angulioris, lying a bit deeper under the others, originating from the canine fossa below the eye, which vertically lifts the angle of the mouth, further deepening that nasolabial fold. So those are the lifters. Pulling against them, gravity and the depressors.
Originating from the oblique line of the mandible, your lower jawline, you have the depressor angulioris. Its fibers converge upwards to insert into the corner of the mouth, pulling it downwards to express sadness or disapproval. Medial to that is the depressor labii inferioris, pulling the lower lip downwards and slightly laterally, exposing the lower teeth.
And right on the point of the chin, you have the mentalis muscle. It originates from the incisive fossa of the mandible deep under the gums and inserts directly outward into the skin of the chin.
And what does it do?
When the mentalis contracts, it wrinkles the skin of the chin, creating that dimpled look, and mechanically pushes the lower lip upward and outward, like when someone is pouting or protruding their lip to sip from a cup.
And we should briefly mention the risorius. It is a highly variable, superficial, transverse muscle. It originates all the way back in the fascia, covering the master muscle near your ear, and runs perfectly horizontally across the cheek to insert into the corner of the mouth. When it fires, it pulls the corners of the mouth straight back laterally, producing a wide, forced, or sometimes insincere-looking grin.
Okay, I want to pause here because we need to look at one specific muscle that feels like a massive outlier in this entire group. We've talked about sphincters, we've talked about delicate elevators for smiling and frowning, but then there is the buccinator.
The buccinator is indeed a fascinating structural exception to almost all the rules we've just laid out.
Right, because when you look at it on a diagram, it doesn't sit superficially directly under the skin like a zygomaticus. It forms the actual fleshy, muscular wall of your cheek, but it's located significantly deeper.
It's quite hidden.
Yeah, it is separated from the other superficial muscles of facial expression by a tough layer called the buccopharyngeal fascia, and it's buried under a distinct encapsulated pad of fat called the buccal fat pad. And while all the other muscles are busy manipulating orifices to express sadness or joy, the buccinator seems to play a massive, heavy-duty mechanical role in human digestion. So my question is, should it really be grouped with the delicate muscles of facial expression?
It is a highly debated point amongst students, but embryologically it belongs exactly where it is. It is a muscle of facial expression by birthright. It develops from the mesenchyme of the second pharyngeal arch, and therefore it is innervated by the facial nerve, CNV7.
But functionally.
But you are correct that anatomically and functionally it straddles two entirely different worlds. Its origins are deep and complex. It arises from the buccal surfaces of the alveolar processes of the maxilla and mandible.
Let me stop you there. Alveolar processes.
The alveolar process is the thickened ridge of bone in your upper and lower jaw that actually contains the sockets for your teeth. So the buccinator is originating right off the bone next to your molar teeth.
Okay, so it's anchored right next to the teeth.
Yes. And posteriorly, at the very back of the mouth, it originates from a vertical tendinous seam called the pterygomandibular raphe. This seam acts as a dividing line.
Like a border.
Exactly. The buccinator attaches to the front of the seam, extending forward into the cheek, while the superior constrictor muscle of the pharynx, the throat, attaches to the back of the seam, extending backward to help you swallow.
So the buccinator forms a continuous muscular wall from the throat, right through the cheek towards the lips. And as its fibers sweep forward through the cheek, the textbook notes they do something structurally brilliant at the corner of the mouth before they join that central hub, the orbicularis oris.
The fiber arrangement is an engineering marvel. As the buccinator approaches the corner of the mouth, the fibers decussate.
Decussate meaning they cross over each other like an X?
Exactly. The upper fascicles of the buccinator dive downwards to enter and blend into the lower lip. The lower fascicles cross upwards to enter and blend into the upper lip. Only the very highest and lowest marginal fibers pass straight across without crossing. This complex weaving firmly anchors the cheek musculature into the mouth sphincter.
It weaves itself entirely into the mouth, but you said it straddles two worlds. What is its actual indispensable day-to-day job?
Its primary function is to maintain the tone of the cheek. It keeps the mucosa, the inside lining of the cheek, pulled tightly taut against the lateral surfaces of the teeth.
For chewing.
Consider the mechanics of mastication chewing. The masseter and temporalis muscles are moving your heavy jawbone up and down, generating tremendous crushing force between your molars. If the buccinator did not exist, the flaccid tissue of your cheek would instantly flop inward right between those grinded molars, and you would savagely bite the inside of your mouth with every single chew.
Ouch. So it physically pulls the cheek out of the danger zone.
More than that, it actively manages the food bolus. When you chew, your tongue pushes the food laterally, outward toward the cheek. The buccinator immediately contracts, pushing the food back inward, directly onto the occlusal grinding surfaces of the teeth.
It's a team effort.
The tongue pushes it out, the buccinator pushes it back. Together, they keep the food trapped in the grinding zone. It is vital for chewing and safely propelling food toward the pharynx for swallowing.
And it has secondary functions, too. It distends the oral vestibule, the space between your cheeks and your gums, and allows you to forcefully compress your cheeks to expel air, which is why it's historically referred to as the trumpeter's muscle. Glass blowers and horn players rely heavily on buccinator tone, and interestingly, it is pierced directly through its muscular substance by a piece of plumbing, the parotid duct, which carries saliva from the parotid gland right through the muscle and into the mouth.
A muscle of many talents. So it is deep, it is functionally tied to chewing, it is pierced by a salivary duct, but it is unequivocally wired as a facial expression muscle.
Now, before we move away from the muscles and talk about that wiring, there's a critical physical consequence of the way all these superficial facial muscles are built. We established early on that they insert directly into the underside of the skin.
Yes. And because their fascicles intermingle directly with the dermis, the superficial face lacks a typical anatomical feature, a deep fascial layer.
Wait, nowhere else is like this?
In almost every other part of the human body, your thighs, your arms, your back, a tough, inelastic, restrictive envelope of deep fascia tightly encases the muscles, strapping them down to the bone and compartmentalizing them. The face does not have this restrictive envelope. The muscles float freely in the subcutaneous tissue.
Why does that matter to a clinician? What is the consequence of missing that deep fascia?
When the skin of the face is lacerated in a trauma or incised surgically by a scalpel, there is no underlying layer of deep fascia holding the wound edges together.
So it just pulls apart.
The underlying muscles, which are directly attached to the torn skin, maintain their resting tone. They actively pull the wound apart. Therefore, lacerations in the face tend to gape widely, far more than a similar cut on the forearm.
The analogy I use is cutting a hole in a stretched trampoline. The instant the fabric is breached, the tension from the springs pulls the hole wide open.
It is exactly like that. Therefore, any facial wound requires meticulous, multi-layered suturing. A surgeon or emergency physician cannot simply stitch the top superficial layer of skin together and expect good outcome.
Because it'll just pull apart again.
They must suture the deeper subcutaneous tissues carefully to counteract the constant lateral muscular pull. If they fail to approximate those deep layers, the tension will stretch the healing tissue, and the patient will be left with a severe, widened, hypertrophic scar.
Structure directly dictating clinical outcome. Okay, we have built the scaffolding, we have hung the curtain, and we've examined the rigors pulling the curtain. Now, we need to talk about how the brain actually orchestrates a symphony of 14 different floating muscles simultaneously in a fraction of a second, just to convey a subtle smirk.
The wiring.
We need to look at the electrical grids. As we established, the face segregates its command signals and its feedback signals into two completely isolated wiring systems. Let's look at the command grid first, the motor system.
The command grid is the exclusive, undisputed domain of cranial nerve the seventh, the facial nerve. As we noted, because all the facial muscles migrate from that second pharyngeal arch, they take the nerve of that arch with them. The anatomy of how this nerve travels from the brain to the face is clinically treacherous.
Walk us through its path.
The facial nerve originates in the brainstem. It exits the brain and enters the dense temporal bone of the skull alongside the vestibulocochlear nerve, the nerve for hearing and balance. It travels through a tiny, serpentine, bony tunnel called the facial canal, curving through the middle ear structure.
Sounds like a tight squeeze.
Eventually, it must exit the base of the skull to reach the outside world. It does this through a very specific, narrow, bony opening called the stylomastoid foramen, located right between the styloid process and the mastoid process behind your ear.
And once it exits that tiny hole in the skull, it has to magically distribute its electrical signals to every single muscle of facial expression across the entire face. But the path it takes to get there is bizarre. It doesn't just fan out under the skin, it drives straight into the middle of a massive salivary gland.
It plunges directly into the deep aspect of the parotid gland, which sits just in front of and below the ear, and it is entirely within the glandular, fleshy substance of the parotid gland that the facial nerve decides to branch.
It's an odd place to branch out.
It first splits into an upper temporofacial division and a lower cervicofacial division. These divisions form a complex looping network within the gland called the parotid plexus. And from this plexus, 5 terminal motor branches fan out across the face, exiting the anterior border of the gland.
And every medical student alive knows the classic mnemonic for these 5 branches. To Zanzibar, by motor car. Temporal, zygomatic, buccal, mandibular, cervical. Let's trace where these wires go once they leave the gland.
The temporal branches emerge from the superior border of the parotid gland. They cross over the zygomatic arch and head north, supplying the muscles of the temple and forehead, specifically the anterior belly of the frontalis, the upper palpebral and orbital parts of the orbicularis oculi, and the corrugator supercilii. They handle the upper quadrant.
The zygomatic branches exit the middle of the gland and fan out over the cheekbone, the zygomatic bone. They serve the lower part of the orbicularis oculi and the subtle muscles around the lateral angle of the eye.
Then we come to the buccal branches. These are typically the largest and most robust of all the terminal branches, and they serve a massive critical territory. They course horizontally forward across the master muscle and onto the cheek.
So they supply the midface.
They supply the procerus, the nasalis on the nose, all the elevators of the upper lip we discussed, the zygomaticus major and minor, the levators, as well as the risorius, the upper half of the orbicularis oris, and crucially, they dive deep to innervate the buccinator muscle itself.
So the buccal branch is doing the heavy lifting for the entire midface and the upper half of the mouth sphincter.
Moving down, we have the mandibular branch, often specified as the marginal mandibular branch. It passes lower down, sometimes looping just below the border of the mandible, running deep to the depressor muscles of the mouth. It provides the motor command to the depressor anguli oris, the depressor labii inferioris, and the mentalis on the chin. There is some slight anatomical variation here, with the massive buccal branch sometimes sending twigs down to assist the mandibular branch in supplying the lower lip.
And finally, the car in our mnemonic, the cervical branch. It drops straight down from the bottom of the parotid gland into the neck to provide motor innervation to the platysma, that broad, thin sheet of superficial muscle that tenses the skin of the neck. So that is the motor grid. A single cranial nerve emerging from a tight bony hole in the skull, dividing within a salivary gland and fanning out across the face to command the entire stage. But what about the feedback grid? How does the brain feel the face?
The face is one of the most highly sensitive, densely innervated regions of the entire human body. The resolution of sensory receptors detecting light, touch, temperature, pressure, and pain is extraordinary, allowing us to sense a single grain of sand on our lip.
It's hypersensitive.
And this vast, high-definition sensory feedback system is governed almost entirely by a separate nerve. Cranial nerve V, the trigeminal nerve.
The trigeminal nerve. The name breaks down beautifully. Tri meaning three, geminal meaning twins or siblings. It has three great divisions. When I try to conceptualize the trigeminal nerve's sensory map, I always visualize a masquerade mask painted on a face divided into three distinct horizontal bands.
That is a highly effective functional spatial model. The three divisions are the ophthalmic division, V1, the maxillary division, V2, and the mandibular division, V3. They originate from a massive ganglion inside the skull, and they enter the superficial face through three entirely different bony portals, mapping out distinct dermatomal territories. Let's start with the top band, the ophthalmic division, V1.
The ophthalmic division, ophthalmic referring to the eye. It enters the superficial face by passing directly through the orbit of the eye.
Yes. It travels through the top of the bony orbit. Its major terminal branches, the supraorbital and supratrochlear nerves, hook upward, exiting the orbit above the eye to supply sensory feedback to the upper eyelid, the conjunctiva, the skin of the forehead, and the midline of the scalp, all the way back to the coronal suture.
And the sides of the eye.
The lacrimal nerve supplies the lateral aspect of the upper eyelid, and the infratrochlear and external nasal nerves supply the medial angle of the eye, the bridge of the nose, and the skin down the sides of the upper nose.
So the V1 band covers the forehead, the upper eye, the bridge, and the tip of the nose. The middle band of our mask is V2, the maxillary division.
V2 primarily enters the superficial face through a distinct hole just below the bony rim of the eye, called the infraorbital foramen. The infraorbital nerve emerges from this hole as a dense tuft of branches. These branches fan out to supply the lower eyelid, the side of the lower nose, the skin of the cheek, the upper lip, and the mucosa of the upper vestibule of the mouth inside.
And the cheekbones.
Other smaller branches, the zygomaticofacial and zygomaticotemporal nerves, pierce the cheekbone to supply the skin over the prominence of the cheek and the side of the temple.
So V2 is the midface. The lower eye, the side of the nose, the cheek, the upper lip, and the upper teeth. And the bottom band of the mask is V3, the mandibular division.
V3 provides sensation to the territory of the lower jaw. Its major sensory branch, the mental nerve, emerges from the mental foramen on the front of the mandible to serve the skin of the shin and the lower lip. The buccal nerve, and here we must be extremely careful, this is a sensory branch of V3, not to be confused with the motor buccal branch of CNDC, supplies sensory feedback to the skin of the lower cheek and the mucosa inside the buccal vestibule. Finally, the auriculotemporal nerve passes upwards, just in front of the ear, to supply the skin of the temple, the temporomandibular joint, and part of the ear itself.
It is a massive sensory net. However, it's important to point out that there is a slight anatomical exception to the trigeminal nerve's absolute monopoly on facial sensation. If you trace the angle of your jaw, the area just in front of your earlobe and over the posterior part of your mandible, that sensation is actually not trigeminal. It is provided by the great auricular nerve, which comes up from the cervical plexus in the spinal cord of the neck.
Exactly. The great auricular nerve overlaps with the V3 territory. And indeed, there is considerable overlap between the borders of V1, V2, and V3 themselves, which contributes to the incredibly high resolution of sensory perception in the face. If a nerve branch is slightly damaged, the adjacent territory can often compensate. Two completely isolated grids. CN as in commanding the muscles, CNV feeling the environment.
Okay, here is where we connect the structure to the disease. The core philosophy of this deep dive. We have built the mental model. Now let's break it. What happens when these highly complex wiring systems fail? Let's look at a failure on the command grid first. A short circuit in cranial nerve 7.
The classic hallmark clinical presentation of isolated facial nerve damage is Bell palsy. It is defined as an acute unilateral lower motor neuron lesion, resulting in the paralysis of the muscles of facial expression on the affected side.
Okay, let's stop and define that term. You said lower motor neuron lesion. What makes it a lower lesion and why does that matter clinically?
It is a vital distinction in neurology. An upper motor neuron is the wire that travels from the cortex of your brain down to the brainstem. A lower motor neuron is the wire that travels from the brainstem out to the actual muscle.
Oh, I see.
Because of how the upper neurons cross over and share wiring in the brain, an upper motor neuron stroke usually only paralyzing the lower half of the face.
Oh, well.
The forehead is spared. But Bell palsy is a lower motor neuron lesion. The damage occurs to the nerve after it leaves the brainstem. Therefore, the entire side of the face, from the forehead down to the chin, is paralyzed.
Got it. And because of the treacherous anatomical path of the facial nerve we just described, this lower nerve is highly vulnerable to physical injury.
Exceedingly vulnerable. Because it travels through the narrow, rigid fallopian canal of the middle ear, a severe middle ear infection, otitis media, can cause the surrounding tissue to swell. In a rigid bony tunnel, swelling causes compression, crushing the nerve and stopping the electrical signal.
That's unfortunate.
Furthermore, because it exits the skull and weaves directly through the substance of the parotid gland, any surgical removal of a parotid tumor carries a massive risk of slicing the delicate nerve branches. It can be severed by deep facial lacerations. It can even be crushed during a difficult forceps delivery at birth because an infant's mastoid process isn't fully developed, leaving the nerve's exit point physically exposed to the crushing force of the metal forceps.
So if the nerve is compressed by swelling or severed, the command signals instantly stop. The riggers drop the curtain. Let's trace the physical symptoms based purely on the functional anatomy we've discussed. If the temporal and zygomatic branches fail, the orbicularis oculi is paralyzed. What does the patient experience?
Without the tone of the orbicularis oculi, the patient loses the mechanical ability to close their eye tightly or even blink reflexively. The unopposed weight of the tissue and the loss of the frontalis lifting it causes ptosis, a severe drooping of the upper eyelid and eyebrow.
And the eye just stays open.
Because they cannot blink, the eye remains perpetually open. This exposes the delicate cornea to continuous drawing from the air, risking severe ulceration, scarring, and potential blindness if the eye is not artificially lubricated and taped shut.
And if the buccal and mandibular branches fail, all those elevators and depressors around the mouth lose their resting tone.
The entire affected side of the face physically sags under the weight of gravity. The deep nasolabial fold, which is maintained by muscle tension, completely flattens out, leaving the face looking strangely asymmetrical and smooth on one side. The corner of the mouth droops downward because the zygomaticus and levator muscles are entirely offline.
But I want to dig deeper into the functional deficits because it's not just cosmetic. Patients with Bell palsy suffer from significant issues with drooling, chewing, and speech. If we apply our anatomical model, why is that happening?
This cascades back to our outlier muscle, the buccinator, and our complex central hub, the orbicularis oris. Let's look at drooling. Without motor command from the buccal branch, the orbicularis oris loses its sphincter tone. It cannot maintain a competent, watertight seal of the lips. Saliva naturally pools in the anterior mouth, and without that muscular dam to hold it back, it simply oozes out of the drooping, paralyzed corner of the mouth.
Wait, if the orbicularis oris is paralyzed, they can't seal their lips. Does that mean consonants like P and B just disappear from their vocabulary? They physically couldn't trap the air to make the sound?
But that is exactly what happens. Try saying the letters P, B, or M without pressing your lips together. You cannot do it. Linguistically, these are labial sounds. They require the precise, forceful closure of the lips to build up air pressure, followed by a sudden release. When the orbicularis oris is paralyzed, articulation of these specific sounds becomes heavily slurred or functionally impossible. Their speech becomes highly indistinct.
And what about chewing?
Furthermore, because the buccinator is paralyzed, it cannot keep the cheek taut. The cheek flops outward. Food gets chronically trapped in the buccal vestibule between the gums and the cheek during chewing, and the patient may repeatedly, painfully bite their own cheek because the muscle isn't pulling it out of the way of the molars. The architecture fails, and the fundamental human functions collapse.
That is a comprehensive failure of the motor grid, a physical paralysis. What about a short circuit in the feedback grid? A failure of the sensory system, the trigeminal nerve.
That presents an entirely different and frankly horrifying clinical picture. The sensory nerve isn't failing to send a signal, it is firing inappropriate max volume signals. The most striking clinical example is trigeminal neuralgia, historically known in medicine as tic douloureux.
Tic douloureux, I believe that translates roughly from French to painful twitch.
A very apt description. Trigeminal neuralgia is widely considered by pain specialists to be one of the most agonizing, debilitating pain conditions known to human medicine. It involves the spontaneous, hyperactive, chaotic firing of the pain fibers within the trigeminal nerve. The etiology, the underlying cause, is often idiopathic, meaning unknown.
but there are suspects.
However, neurologists frequently find it is associated with a vascular loop, a small artery inside the skull physically resting on and pulsing against the root of the trigeminal nerve, wearing away its myelin insulation over years, causing the nerve to short circuit. It can also be triggered peripherally by severe dental caries deep tooth decay that inflames the V2 or V3 branches.
So what is the patient actually experiencing in the ER? What does a short circuit feel like?
They experience sudden, shock-like, excruciating, lancinating electrical pain shooting violently across the face. It typically affects the dermatomal territories of the maxillary V2 or mandibular V3 divisions. V1 is less commonly involved. So the patient feels a searing electrical storm across the cheek, the upper lip, the lower jaw, deep into the teeth and along the gums.
And from what I understand, this lightning strike of pain can be triggered by almost nothing.
The nerve fibers become incredibly hypersensitized. The patient develops trigger zones on their face. The lightest, most innocuous tactile stimulation, a cool breeze hitting the cheek, the vibration of brushing their teeth, the mechanical action of chewing food, or even the slight movement of the skin during normal talking can trigger a debilitating screaming attack. The pain is so severe, so psychologically breaking, that patients will physically shield their face with their hands, they will stop talking, and they will become malnourished because they are too terrified to eat.
That is a nightmare scenario.
Yeah.
How does a clinician even begin to treat an electrical storm in a sensory nerve like that?
Pharmacological management with anticonvulsant medications to quiet the nerve firing is always the first line of defense. But when medication fails, the anatomical interventions become drastically destructive, highlighting just how high the stakes are in these neural pathways. Clinicians may resort to mapping the specific nerve branch and injecting absolute alcohol directly into the affected trigeminal division at the bony foramen.
Alcohol.
Yes, the alcohol literally denatures the proteins and deliberately destroys the nerve fibers, trading the pain for temporary numbness until the nerve regrows.
And if that doesn't work?
In the most refractory, severe cases, neurosurgeons will open the skull and physically section cut the sensory root of the trigeminal nerve deep in the brain, right between the pons of the brainstem and the trigeminal ganglion. They permanently sever the wire. You'd trade the agonizing electrical pain for permanent, irreversible anesthesia of that entire side of the face. You cure the pain by permanently blinding the brain to the face.
We've covered the complex scaffolding, the muscular curtain, and the two isolated wiring systems. Now, we finally need to talk about the plumbing, the vascular system. As we said, the human face is exposed to the harsh elements. It is constantly in violent motion as we chew and speak, and it houses our primary energy-hungry sensory organs. Its metabolic demands are enormous.
To meet those unrelenting demands, the face is highly vascularized. It receives its arterial blood supply from a vast, redundant, interlinked network derived from both the external carotid artery in the neck and the internal carotid artery deep inside the skull.
Let's map the arteries. The dominant heavy lifting supply comes from the external carotid system.
The major defining vessel of the superficial face is the facial artery. It branches off the external carotid deep in the neck, loops upward over the lower inferior border of the mandible, usually just anterior to the heavy masseter muscle, and begins a highly tortuous, winding serpentine path diagonally up across the face toward the eye.
Why is it tortuous? Why wouldn't the body just run a straight, efficient pipe from the jaw to the eye?
Because the face is a highly mobile, dynamic stage. A straight, taut blood vessel would instantly tear or snap when you drop your jaw wide open to yawn or stretch your cheeks to smile. The tortuosity, the slack in the line, allows the facial artery to easily accommodate extreme, rapid facial movements without compromising blood flow. As it travels diagonally, passing deep to the zygomaticus major and the risorius muscles, it gives off vital branches.
Like the inferior labial artery diving into the lower lip and the superior labial artery feeding the upper lip.
Exactly. It then continues upward alongside the nose, giving off the lateral nasal artery to supply the cartilaginous wing and bridge of the nose, and finally it terminates at the medial corner of the eye, where it changes its name to the angular artery.
Aside from the winding facial artery, what else is coming from the external carotid to feed the face?
You have the superficial temporal artery, which is a terminal branch that ascends straight up, right in front of the ear, to supply the temporal region and the lateral aspect of the scalp. You can often see this artery pulsing on the side of someone's head when they are angry. It gives off the transverse facial artery, which runs horizontally across the cheekbone to supply the parotid gland and its duct. Furthermore, coming from deep within the skull, branches of the maxillary artery emerge onto the face through bony holes. The infraorbital artery below the eye, the buccal artery to the deep cheek, and the mental artery to the chin.
And contributing to the top of the face, acting as a secondary system, we have branches dropping down from the internal carotid system, which primarily feeds the brain.
Yes. Inside the cranial vault, the internal carotid gives off the ophthalmic artery to feed the eye. Branches of this ophthalmic artery, the supraorbital and supratrochlear arteries, exit the orbit to supply the upper eyelid and the vast expanse of the forehead, while the dorsal nasal artery exits to supply the upper bridge of the nose.
Okay, let's put this arterial map to a practical test. Let's say a patient suffers a severe, deep laceration to the cheek, and they are bleeding heavily from a severed facial artery. We know exactly where the facial artery crosses the solid bone of the mandible, right at the edge of the jaw. Can a first responder just press their thumb incredibly hard on that specific spot, compress the facial artery against the bone, and stop the bleeding?
Compressing the facial artery against the mandible is a standard pressure point. It will certainly diminish the pulsatile, spurting arterial flow to that side of the face. But to answer your question directly, no. It will not completely starve the tissue or definitively stop the bleeding in a deep wound.
Why not? If you kink the garden hose at the source, the water should stop.
Because the face operates on the principle of extreme arterial redundancy. The terminal branches of all these diverse arteries we just named do not simply end. They form an incredibly extensive, interconnected, and anastomotic network.
Anastomoses, meaning the vessels physically join together to share blood flow.
Precisely. They communicate freely across the midline of the face with the identical arteries of the opposite side. Your right superior labial artery joins directly with your left superior labial artery in the upper lip. Furthermore, they anastomose vertically, establishing open connections between the external carotid system of the lower face and the internal carotid system of the upper face.
So if you put a thumb block on the main highway at the jaw, the blood just immediately reroutes itself backwards through a dozen tiny side streets.
Exactly. Blood from the opposite facial artery or from the superficial temporal artery or flowing downward from the ophthalmic artery will rapidly backflow through these open anastomoses and continue to supply the lacerated area from multiple different directions. Evolutionarily, this rich, redundant blood supply ensures that facial tissue can survive severe trauma, frostbite, or disease without undergoing ischemia and dying. But clinically, it means that controlling severe, deep facial hemorrhage is mechanically very difficult. You often have to clamp and ligate both ends of a severed facial vessel to achieve total hemostasis.
Okay, that is the arterial supply line. Heavy, redundant, and impossible to shut off. Now let's look at the drainage, the venous system. And this brings us back to our hook at the very beginning of the deep dive. This is where the anatomy gets genuinely frightening.
The venous drainage of the superficial face largely mirrors and parallels the arterial supply. You have a main facial vein that begins at the medial corner of the eye as the angular vein. It runs diagonally downward across the face, running right alongside the tortuous facial artery, passing deep to the zygomaticus muscles, and eventually draining safely down into the internal jugular vein in the deep neck.
But there is a massive defining structural quirk to these facial veins that creates an unbelievable vulnerability.
The veins of the face do not possess valves.
Let's put that in context. In almost everywhere else in the body, particularly in your arms and legs, veins have delicate one-way valves built into their walls. They act like mechanical turnstiles. The blood gets pushed upward toward the heart, and the valve instantly snaps shut behind it, so gravity cannot pull the blood back down into your feet. It enforces one-way traffic.
Correct. But in the human face, these venous pipes are just open, valveless, bidirectional tubes. This structural omission means that the direction of venous blood flow in the face is dictated entirely by local pressure gradients and gravity. Normally, the blood flows downward, draining into the jugular. But if the internal tissue pressure in the face suddenly changes, the flow of blood can easily reverse. It can move retrograde.
It can flow backwards. And where does it flow backwards to?
This brings us to a specific topographical region clinically referred to as the danger triangle of the face.
The danger triangle. If you were listening, imagine drawing a triangle on your face. The top point is the bridge of your nose, right between your eyes. The base of the triangle runs horizontally straight across your upper lip from the corner of your mouth to the other. So it covers your nose, the sides of your nose, and your upper maxilla.
The venous drainage of this specific, highly active triangular area feeds directly into the facial vein. Now follow the anatomical pathways. At the upper angle of this triangle, near the eye, the facial vein communicates directly with the superior and inferior ophthalmic veins, which dive deep backward into the bony orbit of the eye. Deeper down the face, the facial vein also communicates via a deep facial vein with a massive hidden network of vessels called the pterygoid venous plexus, located deep behind your cheekbone.
And where did those ophthalmic veins in that pterygoid plexus eventually go?
They both pass directly inward, threading through fissures in the base of the skull, and they empty their venous blood directly into the cavernous sinus.
The cavernous sinus. I want to be crystal clear about what this structure is because the word sinus usually makes people think of the air spaces in their nose that get blocked during a cold. That is not what this is. The cavernous sinus is a massive, complex pool of venous blood situated deep inside the cranial vault, resting right on the base of the skull, surrounding the pituitary gland and sitting directly adjacent to the brain itself.
Exactly, it is a dural venous sinus. So looking at the entire interconnected system, because there are no valves, you have a direct, open fluid connection spanning from the superficial skin of your upper lip and nose, straight through the skull into a pool of blood bathing the underside of your brain.
So let's walk through the exact pathophysiology of the scenario we introduced at the top of the show. What actually happens if a patient gets a seemingly minor infection inside this danger triangle? Say, a severe pimple on the nose, a boil, or an infected hair follicle in the nasal vestibule.
Under normal circumstances, your immune system walls off the infection. It creates a small, localized abscess. But humans are meddlers. If the patient physically tampers with it, if they pinch, squeeze, or forcefully pop that boil to drain it, their fingers are applying immense mechanical compression. This creates an immediate, massive spike in local tissue pressure around the infection.
They are literally squeezing the pus, the bacteria, and the inflamed fluid into those open valveless veins.
Because the pressure gradient is now violently pushing inward, away from the fingers, the infected venous blood flows retrograde. It travels backwards up the facial vein, it enters the ophthalmic veins, it travels straight back through the skull base, and it dumps the virulent bacteria directly into the cavernous sinus.
And what is the clinical outcome of dumping bacteria into the base of the brain?
The bacteria rapidly seed the cavernous sinus, initiating a condition known as cavernous sinus thrombophlebitis. The massive sinus becomes severely inflamed and begins to fill with thick, infected blood clots. This is a catastrophic, rapidly progressive, life-threatening neurological condition. It causes severe cerebral edema brain swelling. Furthermore, several critical cranial nerves, 3, 4, V1, V2, and 6, travel directly through the cavernous sinus. As the sinus swells, these nerves are crushed, leading to paralysis of eye movements and severe facial pain. If not aggressively treated with intravenous antibiotics and anticoagulants, the infection will rapidly spread to the meninges and the brain tissue, leading to a fatal brain abscess or massive cerebral venous thrombosis.
Death resulting from a squeezed pimple on the nose.
Yes. And it is entirely 100% due to the specific structural relationship between the superficial face and the deep cranial vault. If those facial veins possessed simple one-way valves, the bacteria could never flow backwards, and the danger triangle would not exist.
And that brings us perfectly full circle to the philosophy we started with. As we synthesize everything we've unpacked today, from the SEALP to the danger triangle, it is abundantly clear that the human face is a marvel of evolutionary architectural brilliance. But it is deeply, inherently compromised by its own sophisticated design. It's a region where muscles don't pull heavy bones to move joints, but instead flow delicately in the skin to express our humanity and guard our senses. It is supplied by an unblockable, redundant loop of arterial blood to keep it alive in the cold. It is commanded by an exposed, highly vulnerable nerve woven straight through a salivary gland, and it is drained by valveless rivers that connect the dirty, exposed surface of our skin directly to our brain.
It is the ultimate example of structure dictating clinical vulnerability. You cannot separate the anatomy from the pathology.
It leaves you with a genuinely provocative, evolutionary thought to mull over. As humans, we rely more heavily than almost any other mammal on nonverbal communication, microexpressions, and facial cues to socialize, to build complex tribes, and to survive as a cooperative species. We absolutely rely on that extreme, redundant vascularity to keep our exposed faces from freezing and dying in harsh climates. But the uncompromising evolutionary trade-off for having that complex, interconnected, valveless, freely moving tissue is that the exact same structural features make facial infections, deep lacerations, and traumatic wounds uniquely and terrifyingly dangerous. You simply cannot have the human expression without the human exposure.
A necessary, beautiful, and dangerous compromise. Now, to truly cement these concepts, we must move from passive listening to active clinical reasoning. We are going to test your newly built mental models with 6 clinical scenarios, focusing heavily on the anatomical relationships and the functional reasoning we've just discussed.
Let's do it. Disguise the test as the emergency room. Here's scenario 1. A patient is rushed into the ER after a severe bicycle accident. They have a deep, gaping laceration straight across their forehead. The wound is bleeding profusely, and despite the paramedic applying firm, direct pressure with a bandage, the bleeding simply will not stop. Based on our anatomical deep dive, what specific structural feature of the scalp is mechanically responsible for this unstoppable bleeding?
The clinician must immediately recognize that while the gaping of the wound is caused by the lack of deep fascia, the profuse, unstoppable hemorrhage is due to the dense connective tissue of the hypodermis layer 2 of the scalp. The arteries are tightly physically bound to this dense tissue via rigid fibrous septa. When the vessel is severed, these fibrous bands mechanically inhibit the smooth muscle in the artery wall from contracting and spasming. The vessel cannot retract. It is held permanently open like a concrete pipe.
Scenario 2. A patient walks into your clinic, panicked. They woke up this morning unable to close their right eye tightly, and you notice the entire right corner of their mouth is drooping severely. They're drooling slightly. A lesion or damage to which specific cranial nerve is responsible for this total unilateral facial collapse.
The clinical presentation is classic Bell palsy, indicating a lower motor neuron lesion of cranial nerve 7th, the facial nerve. It provides the sole motor command to all the muscles of facial expression. Damage to this nerve paralyzes the orbicularis oculi, eliminating the blink reflex and preventing eye closure, and it paralyzes the elevators of the lip like the zygomaticus major, allowing gravity to pull the mouth downward.
Scenario 3. A patient is recovering from a severe dental infection in their upper front teeth right under the nose. Over a few days, the infection spreads upward into the tissue of the upper lip and lateral nose. They suddenly develop severe headaches, high fever, and their eye stops moving properly. Which intracranial structure is at the most immediate risk of thrombosis due to the valveless nature of the venous drainage in this area?
The patient has an infection within the danger triangle of the face. The venous drainage of this area feeds into the facial vein. Because facial veins lack valves, the increased pressure and inflammation cause the infected blood to flow retrograde, backwards through the superior ophthalmic vein and the pterygoid plexus. Both of these pathways empty directly into the cavernous sinus at the base of the brain, putting the patient at imminent risk for cavernous sinus thrombophlebitis.
Scenario 4. You are observing a patient eating a meal. They are chewing efficiently, but they complain that they are constantly painfully biting the inside of their cheek on the left side. What specific muscle, critical for managing the food bolus, is likely lacking tone or failing to contract properly?
The muscle failing here is the buccinator. While it is embryologically a muscle of facial expression innervated by the facial nerve, its deep anatomical position and structural role of pressing the mucosa of the cheek tightly against the lateral surfaces of the teeth make it indispensable for chewing. If it fails, the flaccid cheek falls between the occlusal surfaces of the molars and is repeatedly bitten.
Scenario 5. A patient reports to neurology experiencing sudden, excruciating, shock-like electrical pain shooting straight across their cheek and upper lip. It is so severe they flinch. They mention that even a light breeze hitting their cheek triggers the agony. Which specific nerve division is short-circuiting and mediating this terrifying sensation?
The presentation of sharp, lancinating, touch-triggered pain in this highly specific dermatome is the hallmark of trigeminal neuralgia. Because the pain covers the cheek, the side of the nose, and the upper lip, it maps perfectly to the maxillary division, or V2, of cranial nerve V, the trigeminal nerve.
Final scenario number 6. Let's go back to the top of the head. If a surgeon needs to make an incision across the scalp, they know they are cutting through the epicranies muscle, which consists of the anterior frontalis and the posterior occipitalis bellies. What is the precise name of the tough intervening structure that physically connects these two muscular bellies across the vast vault of the skull?
The surgeon is cutting through the gullia aponeurotica. It is the A in the SKLP mnemonic, the thick, tendinous, fibrous aponeurotic sheet that spans the calvaria, physically tying the anterior and posterior muscle bellies into a single, cohesive, functional epicranius unit.
Think about all of this the next time you smile at a stranger, blink away a piece of dust, or notice a throbbing pulse in your temple when you're stressed. Every tiny movement is a perfectly choreographed pull on the curtain, powered by an exposed electrical grid, fed by a tortuous looping artery, and drained by a silent river with no gates.
Here are the details of this episode. Key takeaways. Facial muscles insert into skin and create expression. All muscles of facial expression are innervated by CN7. Sensory supply is via the three divisions of CNV. The face is highly vascular with extensive arterial anastomosis. Facial veins are valveless bidirectional flow. The danger triangle allows infection to spread to the cavernous sinus. The facial nerve branches within the parotid gland. The buccinator is key for mastication and oral control.